Hi, my name is Bashla and I created this class. I just wanted to take a minute to welcome you to it. And if you're here, I'm assuming that you're either a NET patient yourself or you're a caretaker for somebody who has NET. So I'm sorry that you're in the circumstances that you have to be here, but I did want to let you know that there's a lot of really good resources out there for NET, both in terms of information that you can find online and in terms of support groups. So you're getting a good start here by coming to this class, and I hope that you benefit from it. The reason that I created it is a couple of years ago, I met my life partner, and he had some health complaints that he didn't talk about with me really very much because he's a pretty stoic person, but I knew that he had some issues. The first time that I actually really thought that something could be wrong, we went to Yosemite and we're hiking up to a big waterfall, and he was just having severe abdominal pain. And it isn't like him to even mention if he's having something that's hurting him. So I knew it had to be pretty bad because he was pretty obviously in pain. We talked with the doctor about it and they didn't see anything wrong. Come to discover that he had been having symptoms for almost 10 years that he kept going to the doctor for, and they kept telling him that it was either irritable bowel syndrome or somebody suggested a disease called sarcoidosis. That's very rare, an autoimmune disease, but they could never actually diagnose what was happening, and he never got any real results from any of his doctor's visits. So anyway, about a year after we met, we decided to move in together. He has two kids. They're now 13 and 14 years old. So we all live together. We decided to have a baby. So I ended up getting pregnant, and then shortly thereafter, when I was about 5 or 6 months pregnant, he went into the doctors again because he was experiencing more pain. And finally, we had a doctor who said, let's take a scan of you and see what's going on, because he had some abdominal issues that were concerning. So it turns out that he had a mass on his pancreas, and it was concerning. They told us that, it could be nothing, or it could be something that we need to worry about. So he went in for more testing, and it confirmed that he did have a tumor on his pancreas and that it had spread to the liver. So what we were originally told by his primary care physician is that he had pancreatic cancer and that they still needed to do some testing to officially confirm it, but it looked like he had about 3 months to live. So this was terrifying news. And I'm sure that many of you have probably experienced something similar if you've been diagnosed, because that is so uncommon that most doctors don't know very much about it at all, and you get a lot of misinformation. But anyway, we spent a terrifying few weeks trying to get it all figured out, wait for additional testing to come in, try to make plans to make sure that his kids were going to be set if he wasn't going to be around anymore. And it was pretty traumatic. So I actually had been working on creating my own business, an online education business, and I quit doing that and just started focusing solely on researching the disease and finding out how we could get him treatment. He was very focused on finding survival stories and finding people who had overcome the disease and figuring out what they had done to be able to do it so that he could be one of the survivors. So we spent a lot of time doing that, and then we finally got a biopsy done for him where they looked at the tissue sample of his tumor, and they told us that it wasn't pancreatic cancer, but it was a neuroendocrine tumor of the pancreas, which has a much better prognosis. It's still very serious, but it's not something where you're looking at a few months usually. People can live for years or even decades, and there's some people that can manage it indefinitely. So that's something that we didn't find out actually until later on in the process either. We kept getting a little bit better and better news. So I'm kind of coming from that perspective with this class, and I know how much work it took and how overwhelming it was to get things figured out with, what the disease is, what types of treatments there are for it, and just everything that goes into having a loved one who you want to survive, and you want to do everything that you can to get the information that you need to make the best treatment decisions and get them the care they need. So what I'm hoping is that this class helps cut out some of that research for you so that you can see from the perspective of a caretaker and her partner what some of the most important things are to learn after you're diagnosed. And even if you've been diagnosed for a while and you want to go back and review some of these things, I hope this class will help you too. So like I said, there's a lot of resources out there on NETs now. So You have a lot of support. Take advantage of support groups. I found them to be really extremely helpful, and I'm not somebody who's usually very into social support type of groups like that. But there's a lot of resources for you. So even though you have something that it would be better if you didn't, you're in a pretty good spot in terms of the amount of support that you can get. So I hope you enjoy this class, and best of luck to you. Before we get started, a couple quick things I need to mention. One is that I'm based in the US, so this presentation is going to be US biased. If you're watching from somewhere else, just be aware of that. The second is that I am not a doctor and I have zero medical training, so please don't rely on this for medical advice. You need to talk with your doctor about your specific case and your treatment, and I just want to make sure that everybody understands that and knows that I'm not legally responsible for you taking any decisions based on what I say in this presentation.
To get the most out of this class, there are a few things I recommend. First, you don't have to watch all of it or watch it in order. You can skip around and watch just the parts that are most useful to you. Secondly, I've included a few downloadable resources that have been really useful to me and that I hope you'll find useful too. Third, studies show that people forget the majority of information that they learn. If there's anything you want to make sure you remember in this class, write it down. Studies also show that when people take notes, they remember information better. Plus, you can quickly go back and reference your notes at any time. Finally, in this course, I mention websites and include videos that I hope will be useful to you. There's a lot of information out there on the internet about NET now, which is a good thing, but it can be overwhelming. I've noticed that sometimes I'll find good information and want to go back to it later, but I can't remember where I saw it. I recommend bookmarking any information that you might want to look at again, and saving it in one or more bookmark folders. For example, you could have a folder for treatment options, one on NET specialists, and one on nutrition.
So in this first section, what I wanted to do is just go over what some of the basics are of NET. It can be really confusing at first, and there's a lot to think about. So I wanted to go over some of the things that were helpful to me in learning about just the basics of it.
In this first part of the course, you're going to learn some basic information about neuroendocrine cancer. You had probably never heard of neuroendocrine cancer, frequently called neuroendocrine tumor, or NET, before you received your diagnosis. It's an uncommon cancer, and outside of the NET community, there's not much awareness about it. Now that you know you have it, though, you're probably anxious to learn exactly what it is and what it will mean for your health. NET patients often get a lot of misinformation before they get properly diagnosed, so let's quickly go over a few things that NET is not. You may have gone a long time experiencing symptoms of the disease before you were correctly diagnosed. My partner had on and off again pain and other digestive symptoms for about a decade and went to a number of doctors who told him he may have everything from irritable bowel syndrome to sarcoidosis, or even told him there was nothing wrong with him at all and he should stop coming in. Some NET patients are told they have anxiety or depression and are imagining their symptoms. It's not uncommon for those NET patients who have been dealing with symptoms to feel a sense of relief in some ways when they're diagnosed. At least they know now that it's not in their imagination and they can start doing something about it. We'll talk more about the staging system for NET a little later, but I wanted to mention briefly that if you've been told you have stage 4 cancer, it isn't always as scary with NET as it is with other types of cancer. The majority of NET patients aren't diagnosed until after their cancer has already advanced or metastasized, and you may have been living with stage 2, 3, or 4 cancer for years without realizing it. Also, if you're a NET patient with a tumor in your pancreas, you don't have pancreatic cancer. When my partner's primary care physician first told him there was a mass on his pancreas, he told him he was probably looking at a few months to live. While this is often the case for pancreatic cancer, also called adenocarcinoma, neuroendocrine tumor usually has a much better prognosis. So where does the name neuroendocrine cancer or neuroendocrine tumor come from? It's called that because it's a cancer type that forms in neuroendocrine cells. These cells carry messages from the nervous system to endocrine system, causing the endocrine system to make and release hormones. Neuroendocrine tumors form when neuroendocrine cells have a mutation in their DNA that tells them to start rapidly multiplying. Neuroendocrine cells are present throughout the body, but the largest numbers of neuroendocrine cells are found in the lungs, pancreas, and gastrointestinal tract. Consequently, these are the most common areas where neuroendocrine tumors develop, though they can develop anywhere neuroendocrine cells exist. About a quarter of NETs develop in the lungs. Lung nets may be asymptomatic, or they may cause wheezing, coughing, shortness of breath, or chest pain. If your net releases hormones, it can also cause symptoms like diarrhea or flushing, which is where your face and sometimes other parts of your skin turn red. There are a few different types of nets that can grow in the lungs. One is a slow-growing net called a typical carcinoid that tends to stay within the lungs. There are also atypical carcinoids, which grow a little faster and tend to spread. Then there are large or small cell carcinomas, which are more aggressive and may be associated with smoking. About 9% of nets are in the pancreas. The pancreas is a 6-inch long gland that sits behind the stomach and below the liver. When doctors describe the pancreas, they often say it's shaped like a fish, with a head, body, and a tail, although to me it looks more like a tadpole than a fish. The pancreas is part of both your digestive and endocrine systems. It makes digestive enzymes that break down food as part of its exocrine function, and hormones that ensure you have the right amount of sugar in your bloodstream and cells as part of its endocrine function. When exocrine cells in your pancreas mutate and begin rapidly reproducing into a tumor, that's called adenocarcinoma, which is the more common and more deadly type of cancer. It is not NET. Pancreatic neuroendocrine tumors form when endocrine cells in your pancreas mutate into a tumor. Pancreatic NETs, which are often abbreviated as PNETs, are usually much more slow-moving and have a better prognosis than adenocarcinoma. The endocrine cells in your pancreas produce the hormones insulin, glucagon, gastrin, vasoactive intestinal peptide, or VIP, and somatostatin. PNETs can sometimes overproduce one or more of these hormones, releasing large amounts into your bloodstream. If you have a tumor that does this, you may experience symptoms like diarrhea, flushing of the skin and face, skin rash, hypoglycemia, pain, digestive issues, gallbladder issues, or changes in weight. Even if your tumor doesn't secrete hormones, simply due to its size or location, it may cause symptoms like diarrhea, indigestion, a lump in the abdomen, pain in the abdomen or back, or jaundice if it's blocked a bile duct. This video by Dr. Eric Liu of the Rocky Mountain Cancer Center explains more about what pancreatic nets are. Another common net location is the small intestine. The small intestine, or small bowel, is part of the GI tract along with the stomach, colon, and rectum. It has the job of absorbing most of the nutrients that we eat and drink. Nets can be found in any of the small intestine's 3 parts: the duodenum, the jejunum, or the ileum. Symptoms may include abdominal pain, constipation, diarrhea, change in stool color, nausea, vomiting, jaundice, heartburn, weight loss, or bloating. Rectal nets are the second most common type of GI net. Symptoms include blood in the stool, pain in the rectum, and constipation, though many patients have no symptoms at all, and their tumors are found incidentally. The majority of rectal nets are small, under 1 centimeter in size. They generally are very slow-moving with a good prognosis, although they can sometimes spread to the lymph nodes or metastasize to distant areas, which is more cause for concern. Nets of the pancreas and GI tract together have a name that's hard to pronounce, so bear with me. Gastroenteropancreatic nets, or GEP nets, GEP nets. In addition to the areas we already discussed, the stomach, appendix, colon, and cecum are all areas where GEP nets can form. More rare sites for nets include the adrenal glands, uterus, ovary, testes, breast, larynx, and other locations. One of the confusing things about neuroendocrine cancer is that not only is it uncommon, but it behaves differently from other forms of cancer. For example, nets are usually slow-moving to the point that when they were first discovered, doctors didn't even think they were cancer and described them as cancer-like. However, we now know that even neuroendocrine tumors that appear to be benign have the potential to become malignant. Because of that, many net specialists recommend considering all nets to be malignant. Another difference is that with other cancers, tumors look kind of like irregular spheres with tendrils shooting out into the surrounding tissue. Neuroendocrine tumors don't have these tendrils. That means when a surgeon is removing a regular tumor, he or she needs to take a wide enough margin of surrounding tissue to make sure the tendrils are cut out too. With NET, your surgeon can take smaller margins. So surgery in the liver, for example, is more doable than it would be otherwise. This isn't always the case, but with neuroendocrine tumors, the primary tumor is often smaller than the metastasized tumors. So you can have a tumor that's very small, even a few millimeters, shooting out cells that cause larger tumors to form. In other cancers, it usually works the other way, with a large tumor generating smaller tumors. Finally, whereas in other cancers there's a standard path of treatment, with neuroendocrine cancer there are hundreds of different variations you could use depending on the characteristics of the tumor. This is one of the many frustrating things about the disease and can take an emotional toll. It's also a very good reason to speak with a NET specialist who has treated patients with many different variations of NET. The fact that there are so many different variations of neuroendocrine tumors ties into the next thing I wanted to mention. You may have heard people refer to NET patients as zebras, or notice that the zebra is the mascot for the disease. That's for a couple of different reasons. One is that no two tumors are alike, and like the stripes on the zebra, no two NET patients are alike. And that's part of why NETs are so hard to diagnose. Some NET patients may present with symptoms similar to irritable bowel syndrome. Others may appear to be having hot flashes related to menopause, and others may not have symptoms at all. In medical school, doctors are taught the phrase, "If you hear hooves, think horses, not zebras." It means that the most obvious explanation is usually the right one. Half of NET patients are first misdiagnosed with another condition, like gastritis or anxiety. Do you have a guess as to what the median time to diagnosis from onset of symptoms is? The answer is 4.3 years, and some studies have shown it goes up to as much as 7 years. My partner visited doctors about his symptoms for nearly a decade before he was diagnosed. NET has historically been thought of as a rare cancer, but that's starting to change. While rates for most other types of cancers has remained fairly stable, the diagnosis of NETs is on the rise. A 2017 study published in JAMA Oncology found that age-adjusted annual incidence of neuroendocrine tumors increased from 1.09 per 100,000 individuals in 1973 to 6.98 per 100,000 in 2012. More than 12,000 people in the United States are diagnosed with a NET each year. And a retrospective review of the National Cancer Institute's database of cancer statistics estimated the prevalence of neuroendocrine tumors in the United States at over 170,000 people in 2014. Estimates of how many people today are living with this diagnosis range from 175,000 to over 200,000. It's likely that many people live and die with this disease without ever knowing it. Autopsy studies in Sweden and Japan conducted decades apart found between 1.2% and 1.6% of people had NETs. In the Japanese study, when they more carefully examined the pancreas with serial sections, a full 10% had NET. As awareness of the disease rises and as medical imaging technology continues to advance, we are likely to keep seeing a rise in the number of people diagnosed. More and more experts are using the word uncommon rather than rare to describe neuroendocrine tumor. Advocates for NET patients have also been pushing to rebrand the disease as uncommon, because a rare disease is less likely to get funding for research or to gain public awareness than one that more people have. When people have heard of the disease, it's usually because of its most well-known patient, Steve Jobs, although his cancer was often misreported as pancreatic cancer rather than a peanut. Steve Jobs was diagnosed at a time when there was even less awareness among physicians about NET and fewer options for treatment than there are today. He lived for 8 years after his diagnosis. Interestingly and sadly, the founder of Siri, who worked closely with Steve Jobs, was also diagnosed with a peanut, but his was in 2016. He had surgery right away to remove his tumor, and fortunately, his scans have been clear since then, at least as of the November 2019 article that you see here that I found on PanCan's website. If you'd like more information on Steve Jobs' case, Ronnie Allen has a good article on his site. Aretha Franklin also had a peanut. It's been reported that neither Steve Jobs nor Aretha Franklin worked with a NET specialist, and some people speculate that their outcomes might have been better if they had. Ruth Bader Ginsburg has not publicly commented that she has a NET, but what we know about her cancer seems to match the description. If she had adenocarcinoma, it would be very unlikely she would have survived this long with it. One of the things you're likely to hear over and over again from people in support groups, from patient advocacy groups, and from your doctor is that with this disease, you're in a marathon, not a sprint. Because NET tends to be slow-moving, and because the disease is usually treated rather than cured, you will likely be dealing with it for the rest of your life, which could be a significant amount of time depending on your circumstances. To orient yourself towards a marathon perspective with your treatment, there are a few things you should consider. One is, if you were recently diagnosed, your emotions and perspective on the disease will likely evolve as you manage it over time. In the short time since my partner was diagnosed a few months ago, I've experienced a wide range of emotions, from relief that he has NET and not adenocarcinoma, to depression, to anxiety over making treatment decisions. I've basically dropped everything else that I'm doing to focus on researching NET and how to get my partner the best care. We're still at a stage where we're scrambling to get things figured out, but long-term patients have advised us to pace ourselves. You are likely to try a number of different treatments over the course of your disease. Prepare yourself for the fact that treatments that work for a while often stop working, and you'll need to move on to a different line of defense. For example, surgery may clear your tumors for a while before they grow back, and then you'll tackle them with targeted therapies. Or you may be on a drug that successfully keeps your tumors from growing for a number of years, but then it stops working, so you'll move on to another strategy. A good doctor will help you time things so you aren't moving too quickly through your options. When you make treatment decisions, talk with your doctor about how they will impact both your overall survivability and your quality of life. My partner at this point wants to extend his life as long as possible so he can see his children grow up, even if that means making choices that diminish his quality of life. While I deeply hope that he can have both a good quality of life and a long life, I can see the merits of choosing a shorter, better quality life, or a longer life. I want him to consider his perspective may change over time, and I will support whatever choices he makes. For a more detailed introduction to NETs, you can watch this 40-minute lecture by NET specialist Dr. Eric Liu of the Rocky Mountain Cancer Center in Denver, Colorado. I watched it shortly after my partner was diagnosed and got so much out of it that I've watched it several times since. Not only is it very informative, but Dr. Liu is a very personable and skilled presenter, so he makes the information easy to follow. As an aside, the chatter from NET support groups about Dr. Liu is that he's an exceptional doctor and a wonderful person who deeply cares about his patients, and who many people credit with saving their lives. Patients do complain that it's hard to work with his office staff because they're so busy, and you have to call multiple times and really hound them to get a response. This seems to be an acceptable trade-off for some people, and others are pretty seriously frustrated by it. In this section, you learned about what neuroendocrine cancer is, where in the body it's located, some of the ways it behaves, and why you should view yourself as being in a marathon, not a sprint. In the next section, you'll learn some of the key terminology related to NET.
When you first start researching NET, there's a lot of information that can be confusing. A lot of the terminology that they use is, you're like, what does this mean? So in this section, I'm going to go over what some of those key phrases are that you hear over and over again so that it can help you get context.
In this section, I'm going to go over some of the words you'll hear tossed around in regard to NET. It can be confusing trying to wrap your head around NET, but once you understand what the different terms mean, it starts to become easier. I've been using the acronym NET a lot in this presentation. NET stands for Neuroendocrine Tumor. NET is used to refer to a single tumor or the disease neuroendocrine cancer. NET's plural is used to refer to multiple tumors. You are likely to see mention of well-differentiated or poorly differentiated tumors. When the cells of a tumor are well-differentiated, it means they look more like healthy cells. When a tumor cells are poorly differentiated, they have mutated to a point where they look less like healthy cells. Grade means how fast your tumor cells are dividing. Grade 1 is a low-grade tumor. These cells divide at a low rate and therefore grow slowly. Grade 2 is an intermediate grade tumor. These cells divide at an intermediate rate. Grade 3 is a high-grade tumor. These cells divide at a fast rate and therefore grow quickly. Tumors are graded by looking at a biopsy of sample tissue from the tumor under a microscope, often using a Ki-67 test. Ki-67 is a protein in cells that increases as cells prepare to divide. A pathologist looks at a strained sample of tissue from your tumor to see what percent of the cells are expressing Ki-67. A high percentage means that the cells are dividing rapidly. If very few cells express it, it means it's growing slowly. Based on what the pathologist sees, they will assign a Ki-67 score between 0% to 100%. A score of 0 to 2%, sometimes 0 to 3%, is grade 1. Up to 20% is grade 2, and above 20% is grade 3. While your Ki-67 score can be a helpful clue, keep in mind that you can have different tumors with different Ki-67 scores. You can even get different Ki-67 scores from different samples within the same tumor. This is why observation of how tumors behave over time is important. Most of us are somewhat familiar with a 4-stage system for cancer, where the lower the stage, the less the cancer has spread in the body. Stage 1 means the tumor is small and hasn't spread beyond the region it started in. Stage 2 means the tumor is larger than stage 1. It's locally advanced but hasn't spread outside the region it started in. Stage 3 means the tumor is large and has spread to nearby lymph nodes or tissue. Stage 4 means the tumor cells have circulated throughout the blood or lymphatic system to a distant region. Your doctor is likely to tell you what stage your NET is using this system because it's relatively easy to understand. However, another staging system called TNM offers more information and is commonly used by doctors for staging NETs and most other types of cancer. The American Joint Committee on Cancer TNM system is based on 3 key pieces of information: the size and extent of the primary tumor, the spread to nearby lymph nodes, and the spread to different sites, which is denoted with an M for metastasis. If you would like to pause here and take a look, you can see the different factors that go into classifying NETs. The website cancer.net also does a really good job of explaining in more depth the TNM system and how NETs are staged. It also goes over variations on staging for different types of NETs, like PNETs or GI NETs. If you'd like more information on how your particular NET is staged, I recommend checking out their site. This 6-minute video from Neuroendocrine Tumor Research Foundation offers a good review of grade, stage, and differentiation, as explained in an accessible way by a top NET specialist.
Most basic variables that we often talk about in the clinic with patients are the 3 dimensions of grade, stage, and primary site, giving us a sense of essentially where the tumor started, how fast it's moving, and where it is now. And I think those 3 variables allow us to at least start the conversation about how we expect the disease to go.
NETs can originate in almost any part of the body. I've listed a few of the common ones. So lung, thymus is an organ that sort of sits up in the chest above the lungs. The stomach, pancreas, small intestine. The small intestine is comprised of 3 parts: the duodenum, the jejunum, and the ileum. The appendix, which attaches kind of right at the junction of the small and the large intestine, and then the colon and the rectum. The small intestine is probably the most common primary site, followed by lung and pancreas.
The site matters because we've learned from at least epidemiology data, like the SEER data, that the prognosis is extremely different even for the same grade and stage of neuroendocrine tumor, depending on where the tumor comes from.
And grade really is a reflection of how rapidly dividing we think the cells are. We can determine that, again, by looking at the cells, how they look under the microscope, and by special stains. 2 key ways that we determine grade are something called Ki-67 and mitotic index. Those are both ways of determining how rapidly dividing the cells are. And that helps us put the grade into 3 buckets: grade 1, grade 2, and grade 3.
The mitotic index is where the pathologist actually counts cells. What they do ideally is to print out about 500 cells or such, and they look at and they visually do a count, and that's gives us the biology as it relates to what we think of in terms of type 1, where the mitotic index is less than 1 mitotic cell per 10 high-power-fields. So that's essentially saying the tumor's not growing. As we go up in aggressiveness, you can see that when we get to 2 to 10, that's a totally different biology. And we want to respect that from how we monitor that patient, surveil that patient, and how we treat that patient with medications.
The other way of doing it, which is even more accurate, is to apply a chemical test to the cells called Ki-67 or Ki-67. This is a chemical reaction that only takes place in cells undergoing cell division, and then you could count them up, or you could even use computer-assisted image analysis and scan very large numbers of cells to determine a percentage of cells dividing.
And differentiation really talks about how the tumor appears relative to a normal appearance of those cells or origin. And usually here we're talking about well-differentiated and poorly differentiated. Well-differentiated tends to have a much slower course. They tend to grow slowly. And the poorly differentiated is a completely different disease. They really have nothing to do with the well-differentiated neuroendocrine tumors.
But the grade and the differentiation are two different things, and they supplement each other. So I think we always need to do both, and there's a lot more interest in doing both now. So all poorly differentiated tumors are high grade. Not all high grade tumors are poorly differentiated. This is incredibly important and has become even more important in recent years.
We often say in medical oncology that we are prisoners of our pathologists and that their interpretation of the specialist is critical to the information that we use to guide our patients. It's very difficult to know if you have a good pathologist, and frequently it means relying on a neuroendocrine tumor medical oncology specialist to make sure that the specimen is read by the right person and interpreted in a clear and consistent way.
We encourage a second opinion pathology review. So I would say that there is expertise that is required for reviewing pathology. So that is a key take-home. This is just an example of what the pathologists look at under the microscope. And it sort of looks just like an abstract picture, probably for many of you, but the pathologist can tell the difference between these three, between grade 1, grade 2, and grade 3 based on these special stains. Stage defines the extent of the cancer, where it has gone to, especially at the time of diagnosis. So more importantly, where is it and can it be removed? So stage and grade often get confused. So remember back to the pathology, that's the grade. That's how fast dividing are those cancer cells. Whereas stage refers to where is the cancer in the body.
We often typically think of whether things are local, stage 1 or 2, whether things involve the regional lymph nodes, which typically make it stage 3, or whether it's distant disease, which we would call stage 4 or metastatic disease. I think it's important for patients to ask their doctors, what is my grade, what is my stage, what is my primary site, and then ask the doctor, based on your understanding and your experience, how would you apply those statistics to me and my particular case?
NETs are classified as either functional or non-functional. A functional NET is a tumor that produces and secretes enough hormones to cause symptoms in a patient. Non-functional NETs may also produce hormones, but not enough to cause symptoms or show elevated hormone levels in tests. About 60% of NETs are non-functioning. Over time, non-functioning NETs may turn into functioning ones, and vice versa. Symptoms associated with functioning NETs can include skin flushing, which is where your face, chest, or other areas turn red, diarrhea, frequent urination, increased thirst, dizziness, shakiness, or skin rash. Non-functioning tumors can also cause symptoms when they grow and take up space in your organs. Mechanical symptoms include pain, jaundice, or changes in your stool. The term carcinoid can be confusing because you hear it a lot in regard to NETs, but then you also see a lot of sources saying that the word shouldn't be used anymore. All NETs used to be called carcinoid tumors or carcinoid cancer. The word carcinoid means cancer-like. People used to think NETs weren't malignant because of how slow-growing they tend to be. But we now know better. Even slow-growing NETs can be malignant, and there are some NETs that are aggressive and grow quickly. Doctors and patient advocates in the NET community have pushed to stop using the word carcinoid because it can lead to the misperception that NETs are not dangerous and that patients don't need to have them treated. To confuse things, NETs found in certain areas of the body, like the lungs and the GI tract, are still often called carcinoids by doctors, although the most up-to-date terms for these tumors are neuroendocrine carcinomas if they're in the lungs, and gastrointestinal NETs if they're in the GI tract. A subset of people with functional tumors have carcinoid syndrome, where one or more tumors produce excess serotonin. Overall, only about 5 to 10% of neuroendocrine tumors result into carcinoid syndrome. Carcinoid syndrome causes symptoms like facial flushing, sweating, diarrhea, shortness of breath, wheezing or asthma-like symptoms, unexplained weight gain, weakness, fast heartbeat, heart murmur, high blood pressure, and significant fluctuations in blood pressure, or carcinoid heart disease, which is a scarring of the heart valves. When people have carcinoid syndrome, it's usually, but not always, caused by NETs that originate in the lungs or small intestines and spread to other areas. Doctors often use the 5-HIAA test to see if you may have carcinoid syndrome, since the amount of 5-HIAA is almost always distinctly increased above normal if you do. Carcinoid crisis causes a severe episode of flushing, low blood pressure, confusion, and breathing difficulty, and it can be fatal. It can occur in people with carcinoid syndrome when they are exposed to certain triggers, including anesthetics used during surgery. Even people with non-functioning tumors who do not normally experience carcinoid syndrome can sometimes experience carcinoid crisis during surgery. Your doctor may give you medication before surgery to reduce the risk of carcinoid crisis. Be cautious with any procedures that involve anesthetics. I even heard a story from someone in one of the NET support groups who experienced carcinoid crisis during a routine dental surgery. I would suggest consulting with a NET specialist before any procedure, and then making sure you convey the information to the person performing the surgery. I would suggest doing it both in writing and verbally in advance of the procedure and on the day of the procedure. A primary tumor is the first tumor that you developed. The type of NET you have is based on where your primary tumor is located. So if your first tumor was in your pancreas, even if it is spread to your liver, those lesions are still classified as pancreatic NET. If a secondary tumor forms, it's because the primary tumor has spread cells into other areas of your body. When NET spread to other areas of your body, this is called metastasis. 58% of NET patients have metastases at diagnosis. If you recall the discussion of staging, this means there's a good chance you have stage 4 cancer when you're diagnosed. Explore thoroughly with your doctor what this means and what your treatment options are, and make sure you get an opinion from a NET specialist. You may also want to turn to help from support groups. If you're in an online support group and you see someone has typed the word METS, as in METS to liver, for example, that means the cancer has metastasized. The liver and lymph nodes are the two most common sites for metastasis. If your tumor has metastasized, you may be able to remove some, but not all of your tumors. When your goal is partial rather than full removal of your tumor burden, that is called debulking. Debulking can be performed to help manage symptoms as well as to help with your survivability. When a NET can't be detected in your body and there are no cancer-related symptoms, this is often called having no evidence of disease, or NED. Because NETs so commonly reoccur, NED patients should still be monitored to make sure their condition remains the same. While some NETs really don't come back, I've heard horror stories of people being told they were cancer-free and no longer needed monitoring, only to have their disease return 1, 5, 10, or even 20 years later. In this section, we discuss some of the key terminology you will hear over and over again when dealing with NET. Don't worry if it's still confusing to you. The more you hear these terms in context, the more you'll start to understand them. In the next section, you'll learn about how NET is diagnosed.
So when my partner was diagnosed, I was pretty much in denial. I refused to believe that he actually had cancer, and I thought, he's been through so much and had so many other things suggested to him that maybe it's actually something else and the doctor doesn't know what he's talking about. So it was really important to me to know how exactly do they diagnose you and what that process is like. So in this section, I'm going to go over how you're diagnosed and what some of the tests are that they're going to use to do that.
When my partner was diagnosed with NETs, it was a process that took a number of tests over several weeks. He first had a scan that showed a suspicious mass in his pancreas, and further testing suggested it was a type of pancreatic cancer that had spread to the liver. He had been misdiagnosed a number of times before, including with irritable bowel syndrome and possibly sarcoidosis. We held out hope that it was actually sarcoidosis until a biopsy confirmed that it was a neuroendocrine tumor. It may take you a series of tests as well before you get a definitive diagnosis. How are NETs discovered and diagnosed? Well, sometimes they're found by accident when you're getting other testing or procedures done. Most often this is with scans or surgery. When it's found incidentally, there's more of a chance that the tumor is caught before it has metastasized and started causing issues. NETs can also be found when your doctor is trying to figure out why you have certain symptoms. Symptoms can be hormonal, like flushing and diarrhea, or mechanical, like pain or blockages of your GI system. For example, a bile duct blockage that results in pale or white stool. There are a number of tests your doctor may use in a workup to diagnose you. Your doctor, for example, may incidentally see something concerning on an ultrasound and then order blood tests to look for the presence of tumor markers, before moving on to ordering an MRI to get a better look at the suspicious mass, and then taking a biopsy of the mass to confirm that it actually has cancerous cells and that it is specifically neuroendocrine tumor. For the information that follows on tests and imaging, I used my own experience with my partner's diagnosis, plus 2 really good sources that I would recommend to anyone who would like more information. One is the Neuroendocrine Tumor Research Foundation puts out a very useful guide for patients and families on neuroendocrine cancer. The guide goes into more depth on a lot of the topics I talk about in this class, including diagnostic testing for NETs, and it's written in an accessible way. I definitely recommend writing to Net Research Foundation and asking for a copy of the booklet. They'll send it to you for free. The other is, Cancer.net also has detailed information that you can access immediately online. In addition to information on how neuroendocrine tumors are diagnosed, they go over a lot of other information you'll likely find useful too. In terms of the tests and imaging you may receive to get your diagnosis, the first one I'll go over is 5-HIAA. This is a urine test or blood test that measures your levels of 5-HIAA. 5-HIAA is a breakdown product of the hormone serotonin. Some NETs produce serotonin, so this can be useful in diagnosing and monitoring neuroendocrine cancer. A lack of excess 5-HIAA doesn't mean you don't have neuroendocrine tumor, since not all NETs produce serotonin. But if your test comes out positive, that can be an indicator that you may have a NET. To take the urine test, your doctor may give you a list of foods to avoid for a couple of days before the test. Then you'll need to use a jug the doctor gives you to collect all of your urine over the course of 24 hours. You'll need to keep it refrigerated, and at the end of 24 hours, you'll bring it back to your doctor for the lab to analyze. The blood test is newer and is not as commonly used at this point, but ask your doctor if it's available, since it's a much more convenient test for you. Chromogranin A is a protein that's secreted by NET cells, and that can be detected in a blood test. This test is sometimes used together with a 5-HIAA test as part of a workup to diagnose a tumor. It's also sometimes performed after diagnosis to watch the tumor's response to treatment and to indicate if your tumor burden is likely shrinking, stable, or increasing. The presence of chromogranin A can sometimes be caused by reasons other than cancer, and it isn't always elevated if you do have a neuroendocrine tumor. So this test is just one piece of the puzzle in diagnosing and managing NET. Magnetic resonance imaging, or MRI for short, uses magnetic fields to produce detailed images of your body and can be used to measure your tumor size. You may have heard the phrase MRI with contrast. That's when the lab tech gives you a special dye called a contrast medium to get a clearer image. This dye may be injected into your vein, or you may take it as a pill or liquid. CT stands for computed tomography. The word tomography comes from the Greek words tomos, meaning slice or section, and graph, meaning drawing. The CAT scan sends X-ray waves through your body to take section-by-section pictures from different angles. A computer combines these pictures into 3D images that show any abnormalities or tumors. CAT scans are useful in measuring your tumor size and seeing if a tumor has spread to other places. Sometimes a special dye called a contrast medium is given before the scan to provide better detail on the image. This dye can be injected into a patient's vein or given as a pill or liquid to swallow. An ultrasound uses sound waves to create a picture of the internal organs. Because tumors generate different echoes of the sound waves than normal tissue, your doctor can use the imaging to locate a mass inside the body. An endoscopy lets the doctor see inside your upper or lower digestive tract. A long, skinny, flexible tube with a camera on it is inserted down your throat or into your anus, depending on the area the doctor wants to observe. You may be sedated as the tube is gently inserted. The endoscope can be used to take a biopsy of the tumor or any suspicious areas. PET, or PET, stands for positron emission tomography. A gallium-68 PET scan uses a small amount of a radioactive drug or tracer called gallium-68 dotatate, which is readily absorbed by NETs that have somatostatin receptors, and between 70 to 90% of NETs do. Areas that light up brightly on the scan have a high uptake of gallium-68, indicating a NET in that location. The brighter it lights up, the more somatostatin receptors there are in the tumor, and the more likely it is to be receptive to treatment with therapies that target somatostatin receptors. A PET scan is usually combined with a CT scan and is called a PET CT scan. If it is suspected that you have a fast-growing NET, your doctor may use FDG as a tracer instead of gallium-68 dotatate. PET scans have mostly replaced Octreoscan, which is less sensitive, but if your doctor doesn't have access to a PET scan, you may receive an Octreoscan instead. You can see how much better at detecting NETs the gallium-68 PET scan is. You should push your doctor to get you one of these scans if there is any facility near you that has the ability to do it. A biopsy is the removal of a small amount of tissue for examination under a microscope. A pathologist then analyzes the samples removed during the biopsy. A biopsy is required to make a NET diagnosis. In my partner's case, his doctor performed an endoscopy with an ultrasound probe and biopsy needle to take what's called a fine needle aspiration biopsy of the mass in his pancreas. His doctors then used the tissue sample to diagnose it as a NET. Genetic testing looks for inherited conditions and syndromes that can increase a person's risk for neuroendocrine cancer. In some cases, knowing you have a genetic syndrome can help you make treatment decisions, and it can also help with early detection in at-risk family members. Now, only about 5 to 10% of NETs are estimated to have a hereditary background, so testing is not done routinely. If you'd like information on testing and if it's right for you, talk to your doctor. Be aware that your insurance company may not cover the costs. If you decide to get tested, make sure you get professional testing, not cheap and inaccurate testing that you can find online. At the time I'm recording this, a reputable company called Strata, S-T-R-A-T-A, offers free testing in the United States for advanced cancer patients. This diagram shows some of the genes with recurrent mutations in NETs, and where in the body these mutations are usually found. Examples of tumor-prone syndromes include multiple endocrine neoplasia type 1, or MEN1, which is associated with around 20 endocrine and non-endocrine tumors, multiple endocrine neoplasia type 2, and von Hippel-Lindau syndrome, or VHL. Ronnie Allen has good additional information on genetic testing on his site. In this section, you learned about how NET is usually discovered in a patient and the diagnostic tools used to confirm you have a neuroendocrine tumor. In the next section, you'll learn how to find a NET specialist to work with.
Since NET is so uncommon and not many local doctors are familiar with it, it's really important that you seek out a NET specialist, someone who has seen multiple other patients with this disease and the many variations that it can take, and that can get you good care based on their experience and their knowledge. Now, I know that that's difficult for some patients, especially if you live in a rural area or your insurance doesn't cover a specialist. I would just say try to see a specialist at least once, and then see if they can guide your care remotely, because a lot of specialists are willing to do that, work with your local oncologist. And if you have a good doctor, they should be receptive to that. But in this section, I'll go over how to find a NET specialist and just some advice on that.
Because NET is so uncommon, regular oncologists often don't have enough experience with it to offer you the best treatment. Finding a specialist can make a big difference in the quality of care you get. There are a number of resources you can use to locate NET specialists. One is a list put out by the organization PanCan. If you call or email them, they'll send you a list of specialists in the areas you tell them you're interested in looking. My partner and I were interested in specialists anywhere in the US, so PanCan sent us a spreadsheet with dozens of options, but they can also send you information on just specialists close to you. Even if you don't have pancreatic NET, the list will be just as valuable to you, since the NET specialists on it handle many different kinds of NETs. Another good resource is NET Research Foundation's Searchable Doctor Database. I have found support groups to be an incredible source of information on all sorts of things, including recommendations on specialists. Before my partner decided which specialists he would be treated by, we spoke with a few different ones off of PanCan's list. Then we posted in support groups asking for feedback from people who had visited them for care. We got some really good personal insight that helped us select the doctor and center we thought would be best for him. There are a number of videos with top NET specialists on YouTube. If there's a specific specialist you're interested in, you can do a search for them in YouTube and see if there are any videos with them in it. If so, this will give you a chance to get a sense for who they are and their approach to NET. You can also watch videos from conferences and panels and see if there are any specialists who jump out at you as someone you would like to have treating you. Of course, you need to be willing to travel if you take this approach. And you will also need to consider whether or not the specialist is in your insurance's network. My partner and I successfully battled our insurance company to see an out-of-network specialist, but it was a time-consuming and draining experience, and we feel very fortunate that we got the outcome we were looking for. Not everyone has the resources or is in good enough health to be able to travel to see a NET specialist. If you live in a rural area, it can be especially challenging to find a specialist within a reasonable distance. Personally, I would recommend trying to see a NET specialist at least once if that's at all possible, even if that means doing it remotely through a telemedicine visit, and arranging to have them work with your local doctor to help guide your care. At the time I'm recording this, telemedicine rules have been relaxed due to COVID-19, and hopefully some of these rules and regulations will remain relaxed. My partner and I spoke with 2 very kind doctors remotely who gave us free consultations since our insurance company refused to let us go out of network. Another one gave us a substantial discount since they knew we were paying out of pocket. Most NET specialists are dedicated to helping patients who need it and are willing to work with you to overcome obstacles. That being said, there are some NET patients who very strongly trust their local oncologist, feel safe in their care, and prefer to just stick with them. While studies show that NET patients who are treated at centers that see a higher medium volume of NET patients have better outcomes than those that see doctors who treat a low volume of NET patients, you have to make that call for yourself.
Before you decide you don't need to see a NET specialist, though, I recommend pausing here for a moment and reading this post from NET patient Jesse Bailey, who gave me permission to copy and paste his comment from a NET support group. He does a powerful job of explaining why you really should do everything in your ability to see a specialist.
In this section, you learned about the advantages of seeing a NET specialist, how to find one, and the fact that specialists are generally willing to work together with your local doctor. In the next section, you'll learn about some of the many treatment options available to NET patients.
So after you're diagnosed with NET, the next thing that you're going to want to know is how can this be treated? Is it something that can be cured, or is it something that I'm going to have to manage long term? And what are the different options that I have? So in this section, we're going to go over that. It's a little bit of a long section because fortunately there are a lot of different treatment options for NET. So you can just skip through to the parts that interest you if you want to do that. Or there's also a bunch more information that I left out that you can get into if you're really interested in treatment.
With most cancers, there's a clear treatment plan that you follow. Because NETs are so heterogeneous, there's no one best way to treat the disease. Educating yourself about the different treatment options will help you understand any recommendations your doctor makes and enable you to share in the decision-making about your treatment plan. This video features a NET specialist and surgeon at Ochsner Medical Center's Neuroendocrine Tumor program, Dr. Rodriguez, who offers advice for patients regarding their treatment.
Quality of life is of utmost importance with this disease. Patients have a multitude of symptoms when they come into the clinic for the first time. They may have diarrhea and flushing or wheezing and weight loss and abdominal pain and really a miserable life for a number of years. And when I see these patients, again, my goal is to try to improve that quality of life. And I often tell my patients, this is going to be a journey. And we've got several different tools that may potentially work for your particular cancer. And we're going to try these and exhaust these and see what works and see what doesn't work. And I often say, if I'm giving you a drug that I think is going to work for your cancer and it is putting you in bed all day and making you miserable, that's the wrong drug for you. We're focused on a disease that I'm not going to cure. This is quality of life is one of the most important things we look for. The neuroendocrine patients come to us from all over the country. They tend to be very well educated, and when I first started doing neuroendocrine cancers several years back, many times patients knew more than I did about their cancer. And they're very good at picking up clues from other patients and saying, oh, maybe I should ask my doctor about this, and maybe I need to be on this particular drug, or this clinical trial is coming down the road. Do you have this? Do you have this particular treatment? And with the internet, there's lots and lots of different support groups out there. And so patients come to us with their questions that they've heard online, and they say, well, am I a candidate for this? Or what do you think about this? And many times these are very good questions that we say, oh, well, yeah, maybe you are a candidate for this, and I'm going to send you here to have this done. And it's good that patients are able to do that, and patients are able to connect. And we see patients from all over the country. So we work with the local oncologist to help facilitate that particular care. So when a patient comes to New Orleans and they live in Nebraska, for instance, there may not be a neuroendocrine expert at that particular site, and that's okay, because we can provide them a roadmap of care and to send back to the local oncologists, and we're open to phone calls and emails and all of these things that go along with that long distance relationship. Need to really become their own best advocate. You'll hear stories about misdiagnosis for years and years. You'll hear and I hear this every day. Patients misdiagnosed, patients put on the wrong treatment, patients told they only have a few weeks to live, and they come to me and I say, well, I've got to try to backpedal and say, well, actually, this is what you have, and this is what we expect to happen, and hopefully you don't have just 2 weeks to live. And I think if they have 2 years or 20 years, I can say, yeah, this is something that you're going to die with rather than from.
If you were fortunate enough to be diagnosed with your NET early, perhaps it was discovered incidentally when you had a scan for an unrelated issue, you may be able to cure it by having it surgically removed. At this point, surgery is the only cure. That means surgery is the only way to entirely remove it from your body and have it permanently gone with no reoccurrence. So you should continue getting scans, because there are often times when it comes back. Many NET patients aren't diagnosed until their disease has started causing significant symptoms, though. And by that time, it is likely advanced to a stage where it has entered the bloodstream. At that point, there are potential seeds of cancer throughout your body, and you can no longer cure it. But just because it isn't curable doesn't mean you can't treat it. Many people with NET are able to manage the disease effectively for years or decades with proper treatment. In this video, Dr. Rodriguez explains how he makes treatment decisions.
When I first see a patient with a neuroendocrine tumor, there's several factors that I look at. One is this tumor localized? Is this something curable? Or has this spread beyond the original site? And my goals vary. So I ask all of my cancer patients, I ask myself the same 3 questions about any cancer patient that I see. Is 1, can this patient be cured? 2, if they cannot be cured, do I have some sort of treatment that is going to at least improve or at least maintain their quality of life? And 3, can I make this patient live longer? So those are the 3 things that come to mind right off the bat. Neuroendocrine tumors are a little bit different than some of the other traditional cancers that we see. Most of the time when I see patients with a neuroendocrine tumor, the cancer is already spread. And I know at that point that this is going to be a long journey for the patient, and the hope is to, again, maintain or improve that quality of life and keep them going as long as possible. There's several different ways that we do that in neuroendocrine tumors. First thing, right off the bat, when I look at a patient, I look at what they look like. Can this patient tolerate any sort of therapy? and I say, well, what kind of therapy do I have to offer this patient? And some of that depends on the pathology. Is this a slow-growing tumor that I have time to send to different specialists and do different sort of treatments? Or is this a very high-grade, poorly differentiated tumor that I need to start the patient on chemotherapy tomorrow? So that is the first thing I look at. Many times with the neuroendocrine tumors, they tend to be on that slow-growing side. I work in a specialized center that has a multidisciplinary approach. We have a tumor board every week where we talk about our patients and come up with treatment decisions as a team. And that's very, very important in this disease. So I work with my surgeons, my GI docs, my radiologists, my nutritionists, and we all get on the same page and figure out the best way to move forward with treatment.
It's always a good idea to get a second opinion. And with NET, you almost always have time to do so, since it's usually a slow-moving disease. A second opinion gives you a different perspective and serves as a quality check. It's a way to confirm your diagnosis and to verify that you've explored and understand all available treatment options. Most doctors encourage second opinions. If yours is threatened by getting one, that may be a sign you should consider switching doctors. Second opinions are useful at any time, but especially at your diagnosis and before proceeding with your treatment plan. Different doctors have different philosophies about the level of aggressiveness to use and which treatment options are best. For example, there seems to be a split, even among NET experts, as to how aggressively to use surgery, with doctors like Dr. Ramirez, who is featured in the previous video, being more likely to use surgery than a doctor like Dr. Kuntz, whose video I will mention later. It's good to hear from 2 or 3 different doctors so you can make an informed decision about your treatment and what will work best with your goals. Let's take a look at the treatments you're most likely to have offered at some point in your marathon. Watchful waiting or active surveillance may be recommended when you were first diagnosed or at other times over the course of the disease. This approach is used most often for a person with low-grade NET that may grow slowly and not spread or cause problems for many months or years. Active treatment usually begins if the tumor shows signs of growing or spreading. With this approach, the tumor is closely monitored with regular tests. Surgery is the only treatment that offers curative potential for NET, but only if it's performed before the tumor has spread beyond its original location. Even if your NET is unable to be cured, surgery can offer some very appealing advantages. One is that by removing the primary tumor, you're preventing it from continuing to send out cells that could metastasize in other locations. Another is that through debulking, you've potentially removed a source of mechanical and hormonal symptoms. What's more, the most common site of metastasis is the liver, and the most common reason patients die of NET is liver failure due to high tumor burden. By surgically removing as few as 70% of the tumors in your liver, you get the same overall survival benefit as removing all of your liver tumors. You're essentially resetting the clock, giving yourself more time and increasing your quality of life by removing one of the sources of symptoms. Surgery also delays the need for using more toxic systemic treatments. This video by Dr. Eric Liu gives a good overview of surgery and neuroendocrine tumor.
So surgery is actually a very effective therapy for neuroendocrine tumors. The reason is because the tumors can cause all kinds of problems. Since they tend to be slow growing, they can cause complications at any time for many, many years. So either they can cause even what we call acute blockages of intestines, or they can cause bleeding, or they can cause chronic pain, or they can secrete hormones, which cause a lot of issues like diarrhea or flushing, or problems with glucose and sugars, or even just weight loss and kind of withering away. So we like to get rid of these tumors as much as possible because you can not only prevent complications in the future, but hopefully get rid of some of that tumor endocrine hormone load. So we always like to have a good neuroendocrine team evaluate you because surgery is so important. But even the technology itself is improved drastically in the past few years. So not only do we have better ways of just doing, using our old tools like scalpels and scissors and things like that, but we have new techniques. So we have new electronic techniques for stopping bleeding. We have ablation technology where you can use heat or microwave or even voltage fields to destroy tumors. And so when you put all these things in combination, and really with the goal of helping the patients, surgery is a very, very important part of the therapeutic regimen.
As we talked about earlier, surgery can trigger what's called a carcinoid crisis, even in patients who don't have carcinoid syndrome. Carcinoid crisis can be fatal, so you want to make sure your surgery team has experience with it and truly understands how to handle it in case it happens to you. Systemic therapy is the use of medication to destroy cancer cells throughout the whole body. Systemic therapies may be given through an IV, orally, or injected into the muscle. A person may receive one type of systemic therapy at a time or a combination of systemic therapies given at the same time. They can also be given as part of a treatment plan that includes surgery and/or radiation therapy. Depending on the type of NET you have, systemic therapies that you may use at some point include somatostatin analogs, chemotherapy, targeted therapy, immunotherapy, PRRT, or radiation therapy. Somatostatin analogs are often the first line of defense in your treatment plan against NETs. They're used to help with symptoms related to NET and hopefully to help stop or slow the growth of tumors. In rare cases, they can reverse tumor growth. My partner's scan after 2 months of taking lanreotide showed that half of the lesions in his liver have shrunk, and the rest have stayed the same size, although his primary tumor has grown slightly. Somatostatin is a hormone that regulates the endocrine system and affects neurotransmission and cell proliferation. When NETs overproduce hormones that cause symptoms like flushing and diarrhea, the somatostatin you naturally produce struggles to keep up with regulating them. Somatostatin analogs introduce synthetic somatostatin into your body with the goal of helping to inhibit hormone production and, to a lesser extent, tumor growth. They do this by attaching to somatostatin receptors in the tumor. Not all tumors have somatostatin receptors. When you get a gallium-68 scan, the more brightly an area lights up, the more somatostatin receptors are there, and the more likely you are to respond to treatment with somatostatin analogs. There are 2 somatostatin analogs in widespread use. Sandostatin, which is the brand name for octreotide and is manufactured by the company Novartis, and somatoline depot, the brand name for lanreotide, which is manufactured by Ipsen. A drug that goes under the brand name Zermelo is another somatostatin analog, but it's used for symptom control only, specifically for diarrhea in patients with carcinoid syndrome. Again, Ronnie Allen has some useful information on lanreotide and octreotide on his site. If you'd like more information, I'd recommend going there. Check the date it was published and be aware that there may be new developments not included. Chemotherapy is the thing most people imagine when they think of cancer treatment. Chemotherapy uses drugs that keep cancer cells from growing, dividing, and making more cells, and usually is administered in a series of cycles over a set period of time. Chemotherapy usually isn't the first treatment used with NETs, though. Your doctor may recommend chemotherapy to treat your NET if it is metastasized, if it's causing severe symptoms, or if hormonal or targeted therapies have stopped working. It can be used alone or in combination with other treatments. Some people experience side effects of chemotherapy, including fatigue, risk of infection, nausea and vomiting, hair loss, loss of appetite, and diarrhea. These side effects usually go away after treatment is finished. Targeted therapy targets the tumor's specific genes, proteins, or the tissue environment that contributes to cancer growth and survival. This type of treatment blocks the growth and spread of tumor cells while limiting damage to healthy cells. Not all tumors have the same targets. To find the most effective treatment, your doctor may run tests to identify the genes, proteins, and other factors in your tumor. This helps doctors better match each patient with the most effective treatment whenever possible. In addition, research studies continue to find out more about specific molecular targets and new treatments directed at them. Everolimus is a targeted therapy used to treat advanced NETs of the GI tract, lung, and pancreas. Its commercial name is Afinitor. While it doesn't usually shrink tumors, it can help slow their growth. Side effects include mouth sores, lowering of blood counts, and fatigue. Sunitinib, which is sold under the brand name Sutent, targets a protein called VEGF. It's approved by the FDA for treatment of advanced pancreatic NETs. Other targeted therapies for NETs are being researched in clinical trials. They include drugs that interfere with new blood vessel formation or with specific survival pathways of cancer cells. Immunotherapy is aimed at boosting your immune system and helping you use your natural defenses to fight the tumor. Also called biologic therapy, the substances it uses are made either by the body or in a lab. Immunotherapy treatments can potentially both lessen symptoms and shrink tumors. At the time of this recording, immunotherapy is not often used with NETs, but there is research being conducted in the hopes of changing that. PRRT is short for peptide receptor radionuclide therapy. It uses a radioactive drug called 177-ludotatate, or Lutathera, that binds to somatostatin receptors and damages the tumor cells. If your gallium-68 scan lit up brightly, that means your tumors have a lot of somatostatin receptors and indicates your tumors may be responsive to PRRT. At the time of this recording, Lutathera has only been approved by the FDA for advanced GI tract NETs and pancreatic NETs, but there are ongoing studies to test its effectiveness with other types of NETs too. Side effects can include nausea and vomiting, elevated enzymes, abdominal pain, low levels of white blood cells, high blood sugar levels, and low levels of potassium. Radiation therapy destroys tumor cells with high-energy X-rays or other particles, and usually involves a number of treatments over a set period of time. It can be used to help relieve pain and other symptoms. Side effects usually go away shortly after treatment and can include fatigue, dry red skin, shortness of breath, or a sore throat. When NET patients develop metastases, the most common place for the disease to spread is to the liver. In fact, 90% of NET patients with metastasis have one or more lesions in the liver. Since liver failure due to tumor burden is a leading cause of eventual death, doctors will often use liver-directed therapies in an attempt to slow, stop, or reverse tumor growth. These therapies include embolization techniques and ablation techniques. Your doctor may recommend using an embolization technique on your tumors when liver surgery can't be performed, and your tumors are either symptomatic or growing in spite of using octreotide or lanreotide therapy. Embolization successfully controls hormonal symptoms in 85% of patients and reduces tumor burden substantially in 55 to 60% of patients. On average, it prevents disease progression to the liver for 1.5 years. There are several different embolization techniques. One is bland embolization, which uses oil, gelatin, or tiny particles to seal off the blood vessels leading to a tumor, blocking the tumor's blood supply. When your doctor uses the same technique as bland embolization, but adds chemotherapeutic drugs to the material blocking the blood vessel, that's called chemoembolization, or more specifically, transarterial chemoembolization, or TACE, T-A-C-E. The idea is to concentrate the drugs directly next to the tumor. Radioembolization uses microscopic resin or glass beads containing a beta radioisotope called yttrium-90, or Y90, to radiate tumors. The beads are sent through the blood vessel that feed the tumor, where they become stuck in the liver and do their job, without radiating much of the surrounding area. The following video explains how it works.
It's a new, life-prolonging alternative for patients diagnosed with liver cancer.
It's used for patients that can't have surgery or can't have a transplant.
It's called Y90, a minimally invasive procedure using radiation directly into the tumor.
Y90 is short for Y90 radioembolization. We actually go through the blood vessels in the groin of the wrist, and we go actually into the blood supply of the tumors, delivering a high dose of radioactive microparticles to deliver a high dose of radiation that serves to kill the tumor from the inside.
Surgeons block the blood supply to the cancer cells and deliver radiation to the tissue while preserving the normal tissue.
Patients handle treatment with Y90 very well. It's actually very well tolerated. There's very few side effects.
The amount of radiation is based on the size of the tumor. Y90 is used when cancer either develops in the liver or spreads to the liver. This procedure was designed to protect the liver and prolong the patient's life.
Well, after the treatment, we will see a usually dramatic change in the tumors. They will commonly decrease in size. Sometimes on the follow-up imaging, they will appear completely dead.
Y90 can also be safely combined with other cancer treatment therapies, so patients on chemotherapy don't have to stop their treatment.
We're finding more and more patients that are being sent for consideration for this procedure.
A procedure aimed at extending and improving the quality of life for patients with inoperable liver tumors. For Lee Health, I'm Lindsay Morton.
Ablation is a term used in medicine to describe the removal of tissue, either by surgery or less invasive techniques. When used on NETs, ablation can reduce the size of tumors and help minimize symptoms. Ablation side effects can sometimes include abdominal pain, infection, and internal bleeding inside the body. Serious complications are not common. 4 kinds of ablation are most commonly used with NETs. Radiofrequency ablation, or RFA for short, uses an electric current to heat and destroy a tumor's tissue. It works best for small tumors. With microwave ablation, your surgeon inserts a needle-like probe into your tumors and then sends electromagnetic microwaves through the probe, heating and killing your tumor's tissues. This treatment is used for larger tumors, up to 6 centimeters. Ethanol alcohol ablation also uses a needle, but it injects concentrated alcohol into your tumor to kill it. Cryosurgery uses a thin metal probe to freeze a tumor and kill its cells, filling it with very cold gases. It can be used with larger tumors than other ablation methods can. Clinical trials are conducted in order to make advances in treatment options. For a drug to become FDA approved, it must undergo a clinical trial. Volunteers participate in clinical trials to help push treatment options forward and to possibly benefit from the treatment being researched. You should talk with your doctor about the pros and cons of joining any particular clinical study. Your doctor should also be able to direct you to resources to find clinical studies. Be aware that there may be a cost for treatments in the study, and your insurance may or may not cover those costs. The following videos show how to find clinical trials.
A clinical trial is a medical research study that involves volunteers and helps doctors find better treatments for cancer. Clinical trials can offer people with cancer additional options for their treatment, and it's important to talk about both the potential benefits and risks of each study with your doctor and the study's research team. Clinical trials are used for all types and stages of cancer.
When patients are seeing their physician to begin to think about how to best treat their cancer, one of the first things that they should think about really are clinical trials. In today's clinical trial environment, the studies are there to help patients and provide the most innovative therapy. And in fact, there are data now to demonstrate that patients that are going on clinical trials actually do better than ones that don't get treated on a clinical trial.
There are many resources available to help you find clinical trials that you may be able to take part in. Talking first with your cancer specialist is a good place to start.
There's sometimes so much information out there that it's hard to coalesce it and really bring it into something that's understandable for the individual. The best place, and usually the first place to start, is by asking their medical oncologist, are there clinical trials that I am eligible for?
Many online resources are also available for patients to research which clinical trials may be right for them. The search for a clinical trial should be a partnership between the patient and their oncologist.
A patient may go on a website, enter a few search criteria, and find a list of clinical trials that may be applicable to their situation. That would be a great time to go back to their physician and say, hey, this is what I found. What makes sense for me? What drugs are you seeing? What do you think might be the best option? And their medical oncologist can help them sort through it. And so it becomes really a back and forth relationship where the patient becomes their best advocate and their medical oncologist really aids in that process.
Clinical trials follow strict rules in order to keep patients safe, structure the research, and study the effects of new treatments. It's important for patients to understand that each clinical trial has specific criteria and that they may not be eligible for certain trials.
We have to understand that clinical trials are essentially a set of rules, and unfortunately, their oncologist or the investigator doesn't have the liberty to break those rules. And sometimes those rules include specific types of patients with different prior therapies or different locations of their disease, et cetera, where the clinical trial is looking for a patient population that might be specific, and unfortunately the patient may not fit into it.
If a patient is not eligible for a certain clinical trial, it doesn't mean that there isn't another clinical trial that is suited for them.
What I encourage patients to do is think about clinical trials, talk to their physician about clinical trials, go into the process with the knowledge that they may not be eligible for every clinical trial that looks attractive, not to get frustrated and continue to think about it throughout their entire treatment process. Even after they've been treated for their cancer, there are a lot of different studies that are looking at survivorship or other issues in patients. There are several internet sites that are excellent. Cancer.net is one of those sites. But in addition to that, there's clinicaltrials.gov. Also, go to the local cancer center website, and most NCI designated cancer centers now will have a specific area on their website that's dedicated to clinical trials.
For more information on what clinical trials are, things to consider in treatment decision making, and how to find a clinical trial that may be right for you, patients and their loved ones can visit cancer.net/clinicaltrials.
One of the best resources, quite honestly, for patients that are trying to navigate not only their disease, but for clinical trials, is cancer.net. It's written in lay language, so that's easy to understand. It also provides links to different clinical trials for that specific situation, and it can really help patients get through what sometimes can be a very confusing process. It's really set up with the patient in mind and to help them navigate the situation.
A lot of people are interested in using herbs or other natural treatments to fight their cancer, in addition to, or sometimes in place of, standard medical treatment. The National Cancer Institute uses the acronym CAM, C-A-M, for Complementary and Alternative Medicine when discussing these treatments. On NCI's website, they include the following information. Complementary medicine is treatments that are used along with standard medical treatments, but are not themselves considered to be standard treatments. One example is using acupuncture to help lessen some of the side effects of cancer treatment. Alternative medicine is treatments that are used instead of standard medical treatments. One example is using a special diet to treat cancer instead of anti-cancer drugs that are prescribed by an oncologist. Integrative medicine is a total approach to medical care that combines standard medicine with the CAM practices that have been shown to be safe and effective. They treat the patient's mind, body, and spirit. Before you use any non-standard medicine, talk with your doctor about it. Even quote-unquote natural treatments like herbs can have properties that actually promote tumor growth or that will interfere with medications you're taking. The video that follows helps explain what to do when considering a complementary or alternative medicine.
Hello, I'm Dr. Jeffrey White from the National Cancer Institute. Dietary supplements, special teas, meditation, and spiritual healing. These therapies are a few examples of the many approaches included in complementary and alternative medicine, or CAM for short. Patients are using therapies such as these in their fight against cancer. Some CAM therapies can be used without causing harm, while other CAM therapies, such as some dietary or herbal supplements, may sometimes be harmful, especially for a cancer patient taking other medications. Deciding to use a CAM therapy is a personal decision, but one that should be made after talking to your doctor. Together you can look for information on whether a CAM therapy is safe and may help. Be wary of a CAM therapy advertised by companies and practitioners as a cure or as having no side effects. Remember that if it sounds too good to be true, it probably is. Instead, look for information about CAM therapies from credible sources, such as the National Cancer Institute. The National Cancer Institute is committed to finding new and promising therapies, including CAM therapies, for people with cancer. Visit www.cancer.gov or call toll-free 1-800-4CANCER. That's 1-800-4CANCER or 1-800-422-6237.
Reputable, evidence-based sources you can use to research complementary and alternative medicine include the National Center for Complementary and Integrative Health, the NCI Office of Cancer Complementary and Alternative Medicine, and the Office of Dietary Supplements. While there are some cases where neuroendocrine cancer is cured, the more frequent situation is a disease-free period followed by distant recurrence. It's important to closely follow up so you can detect any recurrence early. Depending on the tempo of disease, the evaluations can vary from every 3 to 24 months. Personally, I would err on the side of more frequent rather than less frequent follow-up. 2 years would make me nervous. Your doctor may monitor you with a combination of biomarkers, cross-sectional scanning, and functional imaging. Another thing I'd recommend is talking with your doctor about palliative care right from the start. Palliative care, or support care, includes managing the physical, emotional, social, and financial aspects of a NET. It's not just something used in end-of-life or hospice situations, and it's an important part of your ongoing care, along with treatments intended to slow, stop, or eliminate the tumor. People who receive palliative care along with treatment for the tumor often have less severe symptoms, better quality of life, and report they're more satisfied with treatment. Talk with your doctor about what palliative care options are available to you, including whether you have access to a case or care manager who can help you understand and navigate your options. Finally, before treatment begins, talk with your doctor about the treatment's goals and make sure they match your overall goals. For example, my partner's goal is to see his children graduate. As a result, he's more focused on extending his life than on comfort, and is willing to use treatments that other patients may prefer to skip or to use as a last resort. I just saw another patient post in the support group that she has decided she would prefer to spend her remaining time making the most of her life, and has decided to stop treatment and travel instead. It's important that you're taking control of your goals, whatever they are, and make sure your doctor understands them, including any changes you make in your goals as time goes on. For more information on treatment options and sequencing of treatment, OncLife has a very informative series with Dr. Kuntz. In this section, you learned about the most common treatments for NETs and some tips and pointers for approaching your treatment. In the next section, you'll learn about some of the factors that influence survivability of NETs.
So I think I mentioned earlier that when my partner was diagnosed, he first got some wrong information about the type of disease he had and what his likely survival rate was. So some people, I know with my partner, after he got that information, he did not want to think about survivability at all. He just wanted to focus on getting better, and he didn't want to know anything about survival rates. So if you're in that position, you might want to skip ahead and miss this section. I will say that I found it useful to learn about it. And in our case, once we did get more information, things became a lot more hopeful. Now, every case is different. And I don't get into specifics here because of that, because every case is different and you can't make any promises or know for sure what any person's going to experience. But in this section, I talk about what some of the different factors are that might influence, how long you might survive and what your prognosis is. So if that's something that's interesting to you, then I think this section will be helpful.
While each NET patient situation and prognosis are different, I'd like to go over some information that may be useful to you when you talk with your doctor about your own prognosis. First, make sure you know what grade your tumor is, what stage it is, and whether it's well or poorly differentiated. A low-grade tumor has the best prognosis, but intermediate tumors can have a favorable prognosis too. High-grade tumors have the worst prognosis, although there are other factors that matter. For example, a tumor that's high-grade but well-differentiated is not as aggressive as a tumor that's high-grade and poorly differentiated. While the stage of your NET relates to your prognosis, with the lower stages having better prognoses, one thing I want to stress is that if you've been told you have stage 4 NET, that doesn't automatically mean your chance of survival is low. Because NET tends to be slow-moving, you may have already had stage 4 cancer for years before it was diagnosed, and may be able to survive for years more, even with no treatment. Not that your doctor is likely to recommend not treating it, and I would definitely seek out an opinion from a NET specialist if they did. Stage is just one piece of the puzzle, along with factors like if your NET is high or low grade, or poorly or well differentiated, as well as some of the other factors I'll go into next. The first is operability. Patients who are able to have their cancer entirely removed by surgery may be cured of the disease, although they should continue to be monitored because of the high likelihood of reoccurrence. Surgery's curative potential is related to stage, because once your tumor has spread, it becomes difficult or impossible to remove all traces of it. Unfortunately, if your tumor was discovered because of symptoms you are having, rather than incidentally, it is likely advanced to a stage where surgery will not be curative. However, even performing debulking surgery, where you remove a substantial amount of your tumor burden, can improve both your symptoms and your overall survivability. In general, the less your tumor burden is, the better your prognosis, all things being equal. The amount of tumor burden in your liver is especially important, since one of the complications NET patients most frequently die of is liver failure. Both surgery and other therapies often focus on managing tumors that have metastasized to your liver. Symptoms of NET can range from mild to severe, and the more severe your symptoms are, the more they can reduce both the quality of your life and your overall survival. For example, carcinoid syndrome and carcinoid heart syndrome can negatively impact your chance of recovery. NET patients with a primary tumor or metastasis in different locations have different average times of overall survival. For example, all things being equal, small bowel patients have longer overall survival rates than pancreatic NET patients do. You can find information online about survival rates for your type of NET, but I'd strongly recommend talking with a NET specialist to get their opinion, because so much will depend on the specifics of your case. Also, the information that's out there now is based on old data from before there were as many treatments as there are now. Again, each case is different, but as my partner and I learned more about his disease and sorted through the information out there, we went from believing he had several months to live to about a 27% chance of surviving 5 years, to being told by specialists that there's a good chance he can manage the disease for decades, and maybe even indefinitely. Your overall health matters too. People who, aside from their cancer, are healthy overall have a better prognosis than those with comorbidities or health issues aside from cancer. The average age at diagnosis for NET patients is 60. Age matters in that younger patients are often more healthy in general and better able to tolerate different types of treatments, which opens them up for more options. On the other hand, older patients who may not have a long life expectancy in any circumstances may be likely to die with the disease rather than of it. Consequently, younger and older patients may find different treatment strategies beneficial. For example, a healthy person in their 30s would probably benefit more from surgery than an 85-year-old with other health conditions would. Certain types of NET can be related to genetic syndromes, and for whatever reason, some people just respond differently to treatments than others. Your own unique genetic makeup will play a role in how your tumor develops. One piece of advice you'll see over and over again in support groups and from patient advocacy organizations is that you should see a doctor who specializes in NET. It can make a big difference in your treatment plan, your quality of life, and your overall survival. As NET survivor and patient Marianne Wallman has said, I think that every patient at some point in their life needs to go and see a specialist, somebody that treats this disease, because local oncologists don't have the time, and it's not their fault. They're treating dozens of different diseases, and we are rare. And a lot of times, there may be only 1 or 2 patients who they've ever seen in their lifetime, and so they really don't have the time to dedicate to it. So at one point during your lifespan, or in the journey, you should see a specialist and then have them work with your local oncologist to get the treatment that you deserve. Marianne knows firsthand why it's so important to see a specialist. Over 7 years, she had 7 colonoscopies, 7 endoscopies, and several wrong diagnoses before being correctly diagnosed with NET. It's not just anecdotal evidence that supports the benefits of seeing a NET specialist. A 2018 study of patients with treatment at medical centers that treat a low, medium, and high number of JEP-NET patients found centers with expertise in JEP-NET treatment have better patient outcomes, including overall survival. They concluded that centralization of care, particularly of more difficult cases, may lead to improved patient outcomes. An advantage to being seen by a center that specializes in NET, not just an individual doctor who is a NET specialist, is that they often conduct clinical studies, which you may benefit from. In this section, you learned about some of the different factors that can impact your prognosis. In the next section, you'll learn some tips on getting the best care.
In this section, I talk about strategies for making sure that you're getting the best care. There are some people who just prefer to leave it up to their doctor and they don't want to think about it and they just want to trust an expert. There are others who really focus on every single aspect, and that is something that I'm doing, and my partner, I feel like to maybe a little bit of a lesser extent even, is doing. But we're really focused on making sure that he's getting the best treatment and care that he can. So in this section, I'm going to go over some things that have been useful to us in making sure that he does that, some factors to consider, and some tips for how to make sure that you're actually getting good care.
If you've ever left a doctor's appointment with unanswered questions, had a doctor who didn't listen to you, or simply felt like you weren't getting the quality of care that you'd like, you know how frustrating it can be. In this section, I'd like to go over some tips that my partner and I have found useful in getting the best care you can. The first tip is that you need to be your own best advocate in everything you do, from selecting your doctors to confirming your diagnosis to arranging your treatment. Even the best doctor will not be as focused on your case as you are. In support groups, I've seen the advice over and over again, the squeaky wheel gets the grease. It's really true. With my partner's case, he's learned that he has to follow up repeatedly to get some of his symptoms addressed. I've also seen doctors forget to follow up on scans, put wrong information in reports, and say they were going to send information that they didn't. I've started making bullet points of anything that requires follow-up after an appointment, and then following up with the doctor until it's done. I've also heard many NET patients talk about how important it is to self-advocate when you get your lanreotide or octreotide injections. Many nurses aren't familiar with how to do it, and if they don't follow the instructions exactly, your shot can be ineffective. A lot of patients print out the instructions and go over them with a nurse in advance. One patient even mentioned he started singing Happy Birthday twice with his nurses as they inject the shot, so he's sure they're not injecting it too quickly. Make sure you do your research on your doctors. What do online reviews from other patients say about them? What experience do they have with NET? Has anyone in online support groups visited them and is willing to comment on their experience with them? You also want to make sure you have a good rapport with your doctor. Good bedside manner isn't just nice to have. Your doctor's ability to communicate with you in a way that puts you at ease can ensure you're comfortable enough to ask questions that will lead to better health outcomes for you. While you should have one specialist who is your point of contact for guiding your care, studies show you will get the best health outcomes if you're treated by a multidisciplinary team. Ideally, the key players will meet together on a tumor board periodically to discuss your care. While having a multidisciplinary team improves your overall care, it can also create questions about who is truly managing it. Talk with your doctors about this and make sure you establish what the proper lines of communication are and which doctor is in charge of overseeing your care overall so that everything is manageable. What you're doing now by taking this course is a great first step at doing your own research. The more informed you are going into appointments, the more you'll get out of them. At the end of this course, I list a number of additional resources that I found useful and think you may too. And through your own internet research, you're bound to find much more information related to the specific type of NET that you have. Make sure you look at the date that everything you read or watched was published. That will help you gauge how useful it may be at this point. One thing I wish I knew when my partner was first diagnosed is that a lot of the studies that are published on survivability are based on data from 2012, before many of the treatments we have available now were in use. Are you the type of person who already has a million questions prepared to ask your doctor? Or are you unsure what to ask? I've come across two good lists that you can use to pick and choose the questions that you feel would help you most. One is Ronnie Allen's list of questions for the newly diagnosed. If you go to his site, you'll see that he also explains the context for each question, so that you understand why you're asking them and what the answers will tell you. The other is the organization PanCan has a great list of questions you can ask your healthcare team about different topics. Because PanCan deals with pancreatic cancer and PNET, some of the questions are specific to the pancreas, but much of it will be useful to other types of NET patients. Make a list of all the questions you want to ask in their order of importance to you. That way, if you run out of time, you can get an answer to your most pressing questions. I also highly recommend documenting and filing the answers to your questions, preferably electronically, so you can easily go back and search for information. I can't stress enough how useful it is to make recordings, or at a minimum to take notes. It's impossible to remember everything your doctor says, even in the best of circumstances. And when you're at a doctor's appointment, chances are you feel anxious about what you're discussing. Your heightened emotion may make it hard for you to properly focus. Most of us have a cell phone these days, and each cell phone has a recording device in it. I record every single conversation with my partner's doctors and every conversation with our insurance company, and then I transfer them to my laptop and keep them in a folder. I can't tell you how many times I've gone back and listened to a conversation and realized there was important information that neither my partner nor I had focused on at first. Listening again also really helps me to understand things that were confusing the first time I heard it. And it gives me a chance to have someone else listen and explain if I still don't get it. Also, there are times when I perceive things in a certain way during the conversation, and when I listened back, I got a different perspective. Listening back has also helped me observe that my anxiety sometimes makes me talk too fast or cut a doctor off before they're really finished explaining something, and it's helped me learn to take a breath and slow down. Knowing I have a recording to listen back to also frees me from having to worry about remembering things or taking notes, so I can really focus on what's being said and on asking the right questions. Having recordings has also been invaluable in my partner's battle with our insurance company to be seen by an out-of-network specialist. I could listen back to each conversation, document which misinformation we were told by our providers on which day, and build the case that we needed to see someone who specializes in NET. As an aside, in our appeal to see a specialist, I also included this text my dad sent me after our first visit with an oncologist to help show that we were getting misinformation. There are so many recognized benefits to having recordings of your conversations that some doctors who work with cancer patients routinely record their visits and provide you with a copy of it. Assuming your doctor doesn't offer that service, you need to decide for yourself if you want to ask your doctor's permission to record or not. In most states, it's legal to record a conversation if just one of the parties knows it's being recorded, but in some states, you must have both parties consent. At the time I'm creating this presentation, it's a felony in 11 states to record your physician without their permission, those states being California, Florida, Illinois, Maryland, Massachusetts, Michigan, Montana, New Hampshire, Oregon, Pennsylvania, and Washington. So just make sure you do your research and find the most up-to-date information before you covertly record anyone. And realize if you visit a doctor in another state, the laws may be different than in your home state. Another important tip is that many people don't think to discuss with their doctors what their treatment goals are. You don't want to be surprised by finding out you and your doctor have made different assumptions. Is your goal to live as long as possible, no matter what treatment is required to make that happen? Is it to live a good quality of life? Are there different treatments that are out of the question for you because you don't want the potential side effects? Talk with your doctor about your desires so that your treatment aligns with your goals. It's okay to ask your doctor to explain something another time or in another way until you really understand it. You may feel embarrassed about doing that, but your doctor is there to help you, and any good doctor will want to make sure you're able to understand the information they're giving you. Be aware that certain social factors like class, race, and gender can factor into the care you receive. For example, most doctors come from a very educated, white-collar background and may have a harder time relating to people who don't. They may also forget that some of the terminology and concepts they take for granted are not common knowledge. The best doctors will be aware of this and work to counterbalance it. You can also help counterbalance this by working to build a rapport with your doctor. In my opinion, it doesn't hurt to make small talk that helps the doctor relate to you as an individual and become personally invested in your care. My parents made a good friend out of my mom's radiologist when she was battling breast cancer. They genuinely like and care about each other and still talk years after my mom was cured. She even helped us read and understand my partner's radiology reports and looked at scans for us. Studies have shown that Black men have better outcomes when seen by Black doctors. If you feel more comfortable speaking with doctors of your own race, I believe you should do it. Unfortunately, unless you're a white or Asian, it may be difficult to find a doctor of your background, but that may be one factor you want to consider when you seek out a specialist. In my partner's case, we consulted with several surgeons before deciding to go to a NET Center of Excellence in New Orleans. Honestly, one of the factors in our decision-making was that they see a diverse group of patients from different race and class backgrounds. Even though our surgeon is not the same race as my partner, she seems to be aware of class and race issues, and he has a good rapport with her. Likewise, you should consider the impact of gender issues. On self-reflection, I have realized that I have internalized sexism that causes me to more readily see men as experts. I need to be aware of that when selecting and communicating with my doctors. While my philosophy in choosing my own doctors is to select whomever I think will provide the best care, I also consider my biases and how to counterbalance them. I'm a firm believer that understanding the dynamics of privilege can help you get better care. I was worried that some doctors may be consciously or unconsciously biased against my partner because he comes from a different background than most doctors do, and he also has tattoos. I deliberately use my class and race privilege to try to get better care for him. For example, I have seen studies that show doctors are less likely to prescribe pain medication for African Americans. My partner had abdominal pain for nearly a decade, and doctors kept telling him there was nothing wrong with him. After we started dating and I saw how he was hurting and not getting results, I went to an appointment with him and made a point to mention to the doctor that my partner is very stoic about pain, and if he complains at all, that means there's really a problem. While that didn't directly lead to his diagnosis, I don't think it hurt either. After he was diagnosed, I also made a letter describing who my partner is, including pictures of his children and the fact that I'm pregnant, talked about interests of his that I thought doctors would relate to, and consciously included markers of my own class and race privilege. I send his letter to every new doctor he works with and have gotten very good responses. I know it's not fair to have to do this, and many people will not have a friend or relative whose privilege they can leverage. But if you're able to, I believe you should do it. If you aren't able to, you may consider having an open conversation about your concerns. Without accusing your doctor, you could mention that you've seen studies showing differences in treatment, so you'd just like to discuss it frankly with your care team to make sure it's something that's on their radar. That can be delicate, though, because unfortunately, if your doctor feels accused, it can backlash. I hate to say it, but if you're a person of color and you have a white friend who can come with you and bring up the issue, you may get better results. Studies have shown that white people respond more positively to discussions of race by other white people. If you've ever had the feeling your doctor may not be right for you, there's a good chance you're correct. It's important to find a doctor who is both knowledgeable and able to communicate with you effectively. Some signs you may need a new doctor include: the doctor doesn't seem to listen to you. The doctor is threatened by you getting a second opinion. The doctor doesn't have the time to make sure you understand what they tell you or to thoroughly answer your questions. The doctor is not very experienced with NET and is not willing to work with a NET specialist to treat you. If you join a patient support group, you'll see all these complaints and many more. A friend I made in one of these groups said she knew her husband needed a second opinion when the first surgeon they visited seemed distracted and was shaking his leg throughout the whole visit, and at one point told her, "You've done too much research." The sheer amount of appointments you have and the different doctors you talk with can be overwhelming. Cancer patients are generally entitled to the help of a case or care manager. Talk with the doctor leading your team and to your insurance company about how you can get this help. A lot of people may offer to help you but are unsure what you actually need. You will often hear things like, "Just let me know if I can help," or "I'm here if you need anything," but it can feel awkward to ask for the help you need. Think about specific things that would actually be useful to you, so when someone offers to help, you can ask them if they would be able to help with that. For example, I'm going to go over some tips for making use of technology to manage your health records later. If this isn't a strong area for you, do you know someone for whom it is? They would probably be happy to sit down and set things up for you. How about someone who can help you read your reports and understand what they mean so you can ask your doctor informed questions? You're going to have a lot on your plate and much to think about, and delegating some of these tasks to people you trust will make things a lot easier for you. At the time I'm recording this, all insurance plans that are in compliance with the Affordable Care Act, as well as Medicare and Medicaid, will cover a certain amount of mental health resources. Don't underestimate the importance of including mental health in part of your overall health. Also, bear in mind that you will be hit by different emotions at different times. Even if you feel like you don't need to talk with a therapist at this moment, it can help to start developing a relationship with one. They'll evaluate you and help determine a baseline for what's normal for you, so if you start to experience any changes, they have a frame of reference. I'm not a super tech-savvy person, but there are a few tech tools that my partner and I have found to be very useful in keeping us organized and able to more efficiently get him the care he needs. I'll go over them with you broadly here without going into how-to details. You can do an internet search to find information on any of these resources that you think might be useful to you. One of the most handy organizational tools for us has been Google Drive. My partner set up a series of health-related folders on it, with different permissions for each folder. Some of it we share with family members, some with physicians, and some only he and I can access. We put things in there like a copy of his insurance card, his medical records, a letter about him that I share with his doctors, and notes we took on our discussions with doctors. He also obtained a CD with all of the imaging from his scans, found a free trial of a program called Asirix DICOM Viewer to download the DICOM files on it, and then converted the images to JPEG files and created an imaging folder with two subfolders, one with the native imaging, the other with JPEGs in case someone is unable to view the native files. This has been a big help in getting his records to doctors quickly, since we don't have to have our provider mail records to outside specialists we consult with. Spreadsheets can come in really handy for staying organized. We have a spreadsheet that we use as an index file for the records in our Google Drive folder. It helps us keep track of all of his reports and imaging, and includes information like what type of test or record it is, which doctor ordered it, what date it was taken, and a direct link to the document. I'd also recommend keeping a spreadsheet where you document all of your doctor's appointments. You never know when this will come in handy for insurance purposes or simply for your own reference. You're likely to have an overwhelming amount of appointments when you're first diagnosed. Keep your family and caretakers in the loop by putting your appointments in an electronic calendar that you can share with others, like Google Calendar. It's also surprisingly easy to forget appointments, so use your calendar or phone alerts to set reminders to yourself when you have an appointment coming up. Doctors usually request for you to fax them records, but how many people have a fax machine? Rather than needing to rely on our provider to fax records, my partner discovered that he could send and receive faxes using Gmail, plus one of any number of services that support faxing by email. Most of these services allow a certain number of pages for free before you start having to pay. YouTube has a bunch of videos about NET, including talks by doctors. As you're watching these videos, there are a couple of useful features that you might not realize are there. One is you can control the playback speed, which comes in really handy if you're trying to learn a lot of information quickly. I usually turn the speed up to 1.5 times the normal speed, but you could also slow a video down if you want to make sure you're catching what someone says. Another useful feature is you can view a transcript of the video. This is handy for skimming through and finding the place in the video you want to start watching, or if you just want to read along so you can make sure you're catching everything. One word of caution though, the transcription is machine generated, so it doesn't always catch exactly what was said. It can also be confusing to read through because people don't talk the way they write. They often use run-on sentences or switch thoughts mid-sentences. Something that sounds okay when you listen to it can look like a jumbled mess when it's typed out verbatim. I use YouTube not only to view videos, but for my own private video library. I used iMovie to convert audio files of several important doctor's appointments into video files, and then I uploaded them to a private YouTube channel that only I can see. Then I used the transcript feature to help me make notes on what was said. Having the files on YouTube also lets me listen back quicker or slower than the original recordings, and easily skip around to different parts to find the sections I'm interested in. Some people love organization and others hate it. I'm not naturally the most organized person, but I can be when needed. I have a folder that I keep on my desktop with everything related to my partner's health. At first I was just throwing everything into one folder, but it soon became apparent I needed subfolders to keep everything organized. Think about the naming conventions you want to use, and if you'd like to include the dates of documents in their file names. Pick a system that will make it easy for you to go back and find the information you need a week, month, year, or even 10 years later. There's so much good information on NET out there that it can get overwhelming. By bookmarking websites that you find useful, you can easily find them again later. Here's how to do it if you haven't before. In this section, you discovered some tips for getting the best possible care. In the next section, you'll learn about some nutritional considerations for NET patients.
Nutrition is a big issue for NET patients and something that you're probably curious about. A lot of NET patients have digestive issues, so if you're experiencing digestive symptoms, then you're obviously going to think about nutrition and how you can help control those. So in this section, I just go over some basic facts about nutrition and provide some resources where you can get more information.
One of the questions you're likely to have after you're diagnosed is if there's a certain diet that's best for NET patients, and if there are foods you should avoid. In fact, a majority of NET patients say they have changed their diet as a result of their disease. While there are tendencies for some foods to be better or worse for NET patients, the best advice I've seen so far is that each person is different, and you'll need to find what works best for your body. You can do this by keeping a food journal of what you eat each day and how you feel, and then looking back to see patterns. Are there certain foods that seem to trigger symptoms? Does eating big meals cause issues for you? Do you feel better when you snack on high protein foods throughout the day than when you load up on big carbohydrate heavy meals? Many NET patients find that foods and drinks that are gentle on your digestive system are best. In general, it also helps to follow the basics of a healthy diet. This includes eating plenty of fruits and vegetables, choosing whole grain foods, eating foods with plenty of protein, limiting highly processed foods, and staying hydrated with water. Depending on where your tumors are located and what hormones they overproduce, if any, you may find there are certain foods that set off symptoms. Some of these more common foods include foods that are high in insoluble fiber, amines, which are naturally occurring chemicals that arise when proteins break down, and are found in high level in aged, overcooked, and processed meats, fermented foods, and certain fruits such as bananas and avocados as they ripen. Fat, sugar, salt, hot spices, alcohol content, caffeine, carbonation, and highly processed foods. If you would like to explore a low or no amine diet, there's a useful 8-page resource by Pamela Mills-Polson that has been circulating in NET support groups. It has a lot of great information for people interested in exploring if this type of diet would help them with their symptoms. You can also check out the NET Research Foundation's list of foods that other NET patients have found to be helpful to eat and to avoid eating. Plus, the NET Research Foundation has some good tips for how to help alleviate diarrhea, which is a common symptom for patients with neuroendocrine tumors. These include eat small, frequent meals, don't drink while you're eating, drink 30 to 45 minutes before a meal, consume 6 to 8 8-ounce glasses of fluid a day, spread fluid out during the day, taking regular sips of water. When you have diarrhea, drink no more than 4 ounces at a time. Freeze food items right away. Dispose of aged, expired items. Throw out leftovers after 48 hours. Pay close attention to food safety to avoid foodborne illness. My partner experiences pain after eating, and his NET specialist recommended that he eat small, frequent meals and avoid high carbohydrate foods, and that seems to be helping him a lot. Wouldn't it be great if you could fight cancer with the foods you eat? So far, there haven't been any miracle foods discovered, but there have been some studies that show that the following foods have limited anti-cancer benefits: garlic, turmeric, burdock, carotenoids, green tea, ginseng, flaxseed, and blueberry phytochemicals. Check with your doctor first before you alter your diet, because some foods can interact with your medicine, can be dangerous if taken in high amounts, or can even promote tumor growth. For example, echinacea has been widely touted as a cancer-fighting herb, but few studies have actually been conducted on it, and some of those that have suggest it can alter the effectiveness of some cancer drugs. Discuss your situation with a nutritionist to get individualized advice. Make sure you let them know about any dietary restrictions you have or special diets you follow. You can also get some good resources online on NET nutrition. If you could use pointers on cooking or want to ask other NET patients for their advice, the Facebook group Nets Get Cooking is a good resource. And there are a number of good videos on nutrition and NET on the internet. Here are a couple that seem useful to me. In this section, you learned about some basic nutrition considerations for NET patients. In the next section, you'll discover additional resources that may help you in your marathon with NET.
So this is the final section of the class, and throughout the class, I had to pick which resources I was going to use. There are so many options out there that it was hard to choose. So here I'm just including some resources that I either didn't mention in the presentation or that I think are so important that I wanted to mention again and highlight, so that you have an opportunity to, on your own, go out and seek them out. I've already mentioned some resources throughout this course, but there are so many other good resources out there for NET patients. In this section, I'll review some of the ones I found to be the most helpful, but there are many others out there. Each NET patient or caretaker has their own preferences, and you will find some of these sources to be more helpful to you than others. You will also find resources outside of these ones that really resonate with you, so do your own research and find what works best for you. You can visit PanCAN's website or use NET Research Foundation's database to find support groups, both in person and online. If you like to meet in person, you may find a support group in your geographic area. Even if the group meets remotely, having access to folks who have experience with local doctors and resources can be invaluable. I found Facebook to be an outstanding platform for NET support groups. There are a number of different groups out there, all focusing on slightly different NET-related issues. Some offer support for high-grade tumors or for specific types of NET, or patients from a specific region, or patients of a certain age group, or NET diet and nutrition. Dr. Liu is a Denver-based surgeon and oncologist who focuses solely on NET and is somewhat of a NET rock star. He presents a lot at NET conferences and has several very informative videos that you can watch on YouTube, like the ones I included earlier in this presentation. He's very personable and he makes things easy to understand. His patients love him and he has a very loyal following. Dr. Liu doesn't post often, though he sometimes hosts Q&A sessions. Most of the benefit of the group comes from reading what other NET patients and caregivers are posting, and having the opportunity to ask questions and get responses from people who have been through what you're experiencing. Dr. Liu's moderators are dedicated volunteers who are genuinely very caring, friendly, and helpful. They will often connect you with others who they know are in your area or who have similar situations to yours,
and they weigh in with their own advice and experiences too. It's pretty impressive how much they're willing to help. Ronnie Allen isn't a doctor. He's a NET patient from the UK who was diagnosed before there was as much information out there about NET as there is today. He took it on himself to become incredibly educated about the disease and to share his wealth of knowledge with others. One of the things I really like about this group is the scientific, no-nonsense approach, and the fact that he doesn't get into identifying as a zebra like some other groups do. I do think that being part of a zebra community can be important for some patients, but others prefer not to have their disease be part of their identity. I think this group speaks really well to people of that mindset. Ronnie and volunteers moderate the comments. They have to approve posts before they go live, and this leads to a well-curated and very useful forum. Ronnie often weighs in personally on posts where people are asking for advice, directing them to resources that he or others have created, or providing insight based on his experience and knowledge. Since Ronnie is based in the UK, his group has a more international membership than Dr. Lou's does. And when you post, it's helpful to mention the country you're in, since things like insurance and standard treatment can vary by country. In addition to Ronnie's Facebook group, he has a website at ronnieallen.net with a ton of information. I find it extremely useful because it's written from a patient's perspective, so he really understands your mindset and what will be useful for you to know. One of the things that was really important to my partner when he was first diagnosed was to find stories of other people who have survived the disease. He wanted to mine the stories for clues as to how they did it and to see that there was hope. You can find survival stories on the websites here: the Carcinoid Cancer Foundation, the NET Patient Foundation, the Healing NET Foundation, and the Neuroendocrine Tumor Research Foundation. There are also many other stories on the web if you search for them. I personally have found support groups to be an excellent source of survivor stories because you can chat with people who have similar situations to yours. It's very inspiring to talk with people who have been living with NETs for long periods of time. YouTube has a bunch of videos on NET. You can find information related to most NET topics out there. I've benefited a lot by watching videos posted from conferences and talks. The organization OncLive has a number of helpful moderated panels with NET experts, and the Neuroendocrine Tumor Research Foundation puts on annual regional patient and caregiver conferences. You can find recordings of both on their respective websites or on YouTube, and the information you'll find there is top-notch. In addition to its conferences, NET Research Foundation puts out a wealth of other extremely useful information, including several of the resources I've already mentioned in this course. I suggest checking out their website for additional information and resources. If you have a pancreatic NET, PanCan is an exceptional resource. In addition to all the invaluable information they post online, if you write to them, they're often able to help with specific requests. They help me by giving me very in-depth, tailored information a couple of different times. Once by helping me locate NET specialists, and once by sending me research articles that help my partner and me write a successful insurance appeal letter. Even if you don't have a pancreatic NET, some other resources may be useful to you. Cancer.net isn't a NET-specific site, but they have a surprising amount of quality information on NET, and it's written in a way that's easy to understand. The website is also very easy to navigate. I used it a lot for my research for this course. NANETS is mostly a resource for physicians, but you may be interested in reading their consensus guidelines on treatment and management of NETs. The guidelines are written for physicians, but if you're comfortable reading literature aimed at medical professionals and deciphering the jargon, you can find current information on what leading NET researchers are recommending. I discovered the Patient Advocate Foundation because PanCan recommended them to my partner and me when we were battling with our insurance company. They have good resources to help you navigate insurance issues, including tips and sample letters for writing an appeal. PanCan also directed us to the Cancer Legal Resource Center, which offers a free patient legal handbook covering issues related to work, healthcare coverage, finances, and end-of-life issues. It also provides webinars and other training on legal issues and educational materials on national and state topics, such as health and disability insurance, estate planning, employment, insurance navigation, genetic discrimination, and more. In support groups, you will sometimes see mention of a woman nicknamed the Insurance Warrior. She's worked successfully with a number of NET patients to help them get their insurance companies to cover their care. She has a couple of books on how to battle your insurance company and several talks that you can find on YouTube. And if she feels like she's a good fit for your case, you can hire her to write appeals letters for you. I took the resources that follow from a list that Cancer.net maintains. I recommend going to their site to find a description of what each resource is and links to access them. Be aware that some of these resources are needs-based or related to specific geographic areas or designed to assist people who meet specific conditions. Some of the resources may be useful to you and others will not. A number of national service organizations are dedicated to helping cancer patients. The Cancer Financial Assistance Coalition is a group of national organizations that provide financial help to patients. They provide a searchable database of financial resources. Cancer Care provides limited financial assistance for copays, transportation, home care, and child care. It also provides a list of sources for financial assistance and a database of organizations providing financial or practical help. Cancer Finances offers an online tool to help guide you through some key topics that may impact your financial situation. Whether you're newly diagnosed or many years past active treatment, this site can help you navigate finances after cancer. Family Reach is a national organization dedicated to eradicating the financial barriers that accompany a cancer diagnosis, a widespread issue known as cancer-related financial toxicity. The Health Well Foundation is an independent nonprofit organization that helps patients with a chronic, life-altering disease afford their medications when health insurance is not enough. The National Foundation for Transplants provides fundraising assistance for patients needing transplants, including bone marrow and stem cell transplants. Triage Cancer is a national nonprofit organization that provides cancer survivorship materials and resources. There are also local service or volunteer organizations that can help, such as Catholic Charities USA, Jewish Social Services, the Lions Club, Lutheran Social Services, the Salvation Army, and others. Some of these organizations offer grants to help cover the cost of treatment and other expenses, while others help with specific services or products, such as travel or medications. A social worker or an internet search can provide you with a list of the organizations. Many hospitals and clinics also maintain a list of service organizations in the community. Groups that offer medication and treatment cost assistance include RxHope.com, which helps patients obtain free or low-cost prescription medicine, the Assist Fund, which provides financial support to chronically ill patients with high-cost medications, Good Days, which provides financial support by covering copays for those with life-altering conditions, Partnership for Prescription Assistance, which helps qualifying patients who lack prescription drug coverage obtain the medications they need, NeedyMeds.com, which is dedicated to helping people locate assistance programs to help them afford their medications and other healthcare costs, Patient Services, Inc., which provides assistance with insurance premiums and copayments for people with chronic diseases. There's also a Medication Assistance Programs Grid for Patients, a PDF, which is compiled, updated, and generously provided by Wendolyn Andrews, Practice Manager, Division of Hematology Oncology at the University of Arizona Cancer Center. Finally, the Patient Access Network Foundation assists patients with out-of-pocket costs associated with their treatment. If you need help with travel costs for treatment, one of these groups may be able to help, but just be forewarned that most of them are limited to certain geographic areas or have other limitations. Air Charity Network, the Corporate Angel Network, Lifeline Pilots, PALS, which stands for Patient Airlift Services, Mercy Medical Angels, Air Compassion for Veterans, Along Comes Hope, and Angel Airline Samaritans. There are also groups that help with lodging. My partner and I have not been able to find one that's operating during COVID-19, except for Airbnb. Hopefully more options will become open again after the pandemic has subsided. These resources include Hope Lodge, which is sponsored by the American Cancer Society, Airbnb, Healthcare Hospitality Network, Extended Stay America Hotel Keys of Hope program, Joe's House, and Ronald McDonald House Charities. There are several groups that offer general financial help to cancer patients. The Patient Advocate Foundation provides education, legal counseling, and referrals for people with cancer who need assistance managing insurance or with financial, debt crisis, and job discrimination issues. It also provides copay assistance and financial aid for eligible patients. Cancer Family Relief Fund is a charitable organization that encourages and facilitates grants to children whose parents or guardian is struggling with a diagnosis of cancer. These grants support the children's extracurricular activities so they may feel some sense of normalcy as their parent focuses on treatment and recovery. The American Childhood Cancer Organization maintains a list of organizations offering financial assistance. Cancer.net has a lot of other good information related to cancer and financial considerations. I recommend checking their site out for more information. Also, if you've paid enough into Social Security, you may qualify for disability benefits under some circumstances. To see if you may be eligible, visit www.ssa.gov/disability. I hope you've benefited from taking this course and feel better prepared than when you started. There are many additional resources available online if you'd like to further explore any of the areas we discussed here or any additional topics. I wish you the best in your marathon against NET.
So that wraps up the class. I hope that you got a lot out of it and that it helped cut down on the time that it would take you to research all this information. And I really wish you the best in your journey with NET.